Afternoon, everybody. It's rather a large topic, and you'll be grateful if I don't keep you here till about 8 o'clock talking about this. There's quite a lot to get through, so it's going to be quite a rapid talk through the causes of hemodynamic instability after cardiac surgery. As you all know, this is a Category 1 indication for a TOE. My scheme keeps on going blank here. I presume this one's okay. Okay. Category 1 indication for TOE in a hemodynamically unstable patient who's not responding to initial measures. But you'll also notice the indication underneath, which states that just if you think this is going to alter your management, that's not necessarily an unstable patient. That's somebody who could be very stable. Let's just do a little bit of tweaking as well. That's not the premise of this talk. I'm going to stick to the guys in the top indication there. Now, the debate between using ultrasound or using a catheter, I think, has pretty much come to a conclusion. I think we all know what we would prefer to do. The two are providing different information, and certainly the echo, it's well established, provides information over and above that of a catheter. Evidence supports that. And as you see from the bottom, there was a review article in Chest 2008 where Paul Marek, an American, his concluding sentence was that CVP should not be used to make clinical decisions regarding fluid therapy. As you can see, he's had a couple of goes at this, and some other people are backing him up as well. So post-cardiac surgery, instability, pretty common, isn't it? I would say it's pretty usual when we push our patients through the door into the intensive care unit, and that systolic blood pressure is 20 millimeters of mercury lower than it was when we left theatre. But I think what's key, and in particular the use of TOE, is in a cardiac surgical patient, there's so many of the causes of that hypertension are mechanical causes, and there are things which can be picked up almost uniquely with TOE. Transthoracic imaging has a part, but it certainly isn't as successful. And that will lead to early intervention and reversal of the whole process with a better outcome for that patient. So let's just go through a few of these issues. My video is not running either for whatever reason. Let's just go back. First of all, is the patient hypovolemic? Now, that patient who arrives with a systolic of 75 with a CVP of 1 or whatever, it's obvious, and they get their fluid resuscitation quickly, and the blood pressure responds to that. It's half an hour later, when they've had their litre and a half of fluid, the blood pressure's not come up. The filling pressures would appear, on a catheter, would appear to be high, normal or even high, but the blood pressure still isn't responding. That's the time for intervention. But what often happens is we stick a TOE probe down and we have a look at the LV, whether it be transgastric, which is fairly routine, a short axis. But it's now been established that looking at that end diastolic diameter is actually not quite the indicator that we thought it was. For sure, if you've got a grossly hypervolemic patient and you get an end systolic area which is just about 0, you've got a big ejection fraction, then yeah. But it's in those patients, and in particular those dilated ventricles with poor systolic function, it's actually not such a good indicator. So what do we do then? There are surrogates of left atrial pressure, which I'm about to come on to. But also, rather than surrogates of left atrial pressure, what might actually be more important is this patient actually going to respond to fluid? And there are ways to get around that, to assess that. Now, I'm not going to go through all the indices of diastolic function and how to estimate left atrial pressure. You all know that, and time will not allow me to do that just now. But what they won't do is actually tell you exactly what the left atrial pressure is. But what it may tell you is whether the left atrial pressure is low or it is high, which is fairly important information. The reliability of that information, in particular with transmitral flow and mitral annular tissue Doppler imaging, becomes somewhat unreliable. In those patients, you really want to know what the filling pressures might be in those patients with really poor ventricles. After all, is it important that we know what the left atrial pressure is when, in fact, what we want to know is this patient needing more fluid? Now, a few things that we can do here, and in my practice, this is not something colleagues from other hospitals tend to talk about very much. But this has been shown in ventilated patients, so long as they're not interacting with a ventilator, including cardiac surgical patients, stroke volume respiratory variance of more than 20%, and also stroke volume as measured with pulse wave Doppler in the LV outflow tract to give you VTI to passive leg raising. What's possibly better than that is the SVCcollapsibility index, and there's quite a lot of literature out there about this, whereby basically, let me show you the next slide. Two images there. I apologize for the quality of the bottom one. The top one, nice image, done wrongly. It's a patient who has a short axis view. Let me just highlight this. Short axis view of the SVC there. There's the left atrium, and M-mode cursor put down there. And what someone's done, I don't know if this shows in the lighting, but they've measured the maximum there and the minimum there, but all within one cardiac cycle. There's the QRS complex there. That's not what you do. It is supposed to be done in a long axis view of the SVC, and it's basically the maximum, which will be with expiration, and the minimum on inspiration. The difference between the two over the maximum gives you that collapsibility index. And a value of over about 35% would suggest that your patient is certainly going to be volume responsive. Now, I think I'm talking to an audience of people who are either cardiac anesthetists or intensivists. How many people actually do this? Could I just see a show of hands? Who does this? 4. Okay. Distributive shock, I'm not going to say too much about. That's usually just that little bit more obvious clinically. And what that image was showing was just that very high ejection fraction with a low end systolic area. There's really 3 causes of that. And there's not too much to see in an echo which is specific to distributive shock other than that. Things in sepsis can change a little bit. Next thing we need to look at is what about that ventricle? How is that ventricle performing? Now, we know that many of our heart will struggle off bypass and then just begins to improve. And the first steps in it doing that is preload recruitment, not just of stroke volume, but actually of contractility. It's something called the length-dependent activation, where your troponin C actually becomes more responsive to calcium. That usually happens very quickly, just with filling the ventricle. And thereafter, we have the so-called stunned ventricle, where calcium handling by the myocyte is just a little bit slowed down, and it just takes some time to wake up. Could be 10 minutes, could be the next 3 weeks, usually closer to about 10 minutes. The RV systolic impairment, that together with diastolic dysfunction, are usually much more longer lasting. They do take just quite a bit of a hit in any patient who's been on a bypass pump. Recent recommendations, which is from the American Society of Echo, is still that we should be looking at global LV function, either on 2D, 3D, looking at ejection fractions. 3D is almost certainly going to be superior to that, but certainly one-dimensional measurements, even two-dimensional measurements of a fractional area change are going to be a poorer surrogate. Let's hope that these run, and they're all going to disappear. Often what we do in a hurry in a hemodynamically unstable patient is get that short axis view which you got a fleeting glimpse of. Either looks normal, it looks terrible, or it looks hyperdynamic. And we can make some judgment from that. If we've got time, then we can go on to looking at fractional area change or ejection fraction. What about the poor right ventricle, which this one down here, you could see very briefly that it actually was struggling. It was actually completely dyskinetic. We've had quite a lot of talk already about the right ventricle and what we need to do. 3D at the moment, it's pretty much offline. The right ventricle is a non-geometric structure. It's very difficult to assess, and it takes some time to accrue the images and assess that in 3D. But certainly TAPS, which we've heard a little bit about already, a 2D fractional area change, and the S-wave are things which are done in everyday practice, which is what we should be doing. What about graft-related dysfunction? Sorry about the images. It's really unhelpful, I'm afraid, that they're just not... They're not projecting. Graft-related dysfunction, very variable incidence, and will be suspected in anybody who's getting new ECG changes. We put a TOE probe down, they're unstable, we get wall motion abnormalities, and we think we're pretty certain we've got a major problem with a graft here. That's not always the case. The sensitivity and specificity of those wall motion abnormalities, new wall motion abnormalities post-grafts, is actually extraordinarily low. And actually having a chat with a surgeon, you can usually get a feel from the surgeon who's done the grafts when they tell you, well, actually that second OM graft was just a little bit dodgy, that anastomosis was very small, poor target. And they usually have an idea and are able to guide you here. To actually take a patient, to reopen a patient on the basis of an ECG, new wall motion abnormality with ECG changes would be quite a big thing to do. And this has been shown with angiography, that actually there's a very, very low positive rate of angiography in these patients with these signs. Anybody know who this chap is? The device on the right-hand side would be a clue. No, this is Claude Beck, an American surgeon, worked in Cleveland, who was the first person to actually defibrillate a heart, which is what the 2 items, a bit Heath Robbins with a couple of spoons on it. That's what he used to defibrillate a patient internally. And he was also the person who came up with Beck's triad. Everybody remember Beck's triad? Yeah, those muffled heart sounds. Patient who's in tamponade with muffled heart sounds, extended jugular veins, and hypotension. I prefer to put TOE ground, but my ears are getting a bit hard of hearing. First described an awful long time ago by Morgagni, with an incidence which is quite variable between different types of surgery. The most common incident of tamponade is post-transplantation. Now, what we tend to see post-cardiac surgery, at least immediately following cardiac surgery, is quite different to that medical patient who's got a large, slowly accruing collection, who eventually gets the classical signs clinically and the classical signs of echo. We actually very rarely see that, and certainly not in about the first 5 to 7 days following surgery. Because what we tend to get is that very localized bleed which sits on top of the right atrium. They don't have the clinical signs other than a low cardiac output with low blood pressure. They don't have that exaggerated ventricular independence. By that I mean the changes in tricuspid and mitral inflow, which you expect to see with classic tamponade. RV diastolic collapse is a relatively late sign. Note also that pericardial tamponade can be caused in anybody with a small pericardial effusion who's got a very large pleural effusion. That pressure from the pleural effusion can be transmitted to the pericardium by that route and can end up with major hemodynamic disturbance as a result. It's anecdotal in the literature, but it does exist, that's for sure. Oh, what a shame. The top image, provided by a couple of my colleagues, showed actually right atrial systolic collapse, and that was with a very localized collection. Up to sort of as little as 60 to 100 mils of blood may have that enough profound effect to drop your blood pressure and produce a shocked patient. And according to Susanna Price, 2004, up to 60% will be missed with a transthoracic post-cardiac surgery. According to Beppu, 100% of his case series were missed with transthoracic imaging, and all were picked up with transoesophageal imaging. Now, often it is very obvious. Sometimes in these two images, it's a little bit more subtle, the right atrium and then the right ventricle with diastolic collapse there. And sometimes it's just downright obvious where you have an utterly shocked patient on the verge of collapse. How people have got the time to put a TOE probe down in those circumstances, not just open the chest, I'm not sure. I'll briefly run through some valvular issues also. Okay. Paravalvular leaks, very common, up to about 50% of patients who are having mechanical mitral valve replacements in particular. Most of those leaks are going to be very small and insignificant, sort of thing you're going to pick up post-bypass and you're not going to have to tell the surgeon about. Quantifying that leak is difficult, and it's suggested that be done with the usual native valve regurgitant features, which is a pretty hard thing to do, and it's a small proportion which are actually going to be clinically significant. 3D looks particularly promising with this. I haven't got any. I did have a 3D color image of a paravalvular leak there. Let's see if we can just bring that back. That's the 2D, there's 3D, both sides of it, and then with color on, and it's gone. And with 3D, what you can do is actually find the actual anatomical regurgitant orifice, and it's thought that actually putting color on and getting an effective regurgitant orifice with color 3D is probably the way to do this. Okay. The incidence of acute prosthetic dysfunction in terms of thrombosis is actually much higher than I had appreciated looking through the literature, up to about 10% by 9 days post-operatively. Very few of those are actually going to have some hemodynamic disturbance, and the reoperation rate is clearly very low. Let me just get this to catch up. Just about there. There it was. That was actually a pregnant woman who was about 28 weeks pregnant who'd had a mitral valve implanted at the age of about 12. This was about 10 years after that, and she came in a shock state, base deficit of about 20, with emergency caesarean section with a redo mitral valve replacement in one go, and did well. What about outflow tract obstruction, which is the sort of chestnut of outflow tract obstruction, goes with mitral repair, producing SAM with dynamic outflow tract obstruction afterwards, which I'll come on to. Also exists following Holcomb repairs and also post-AVR. There's sort of 88-year-olds who've got a big, big, thick muscle mass, small chamber size. They have their AVR done and they've got outflow tract obstruction afterwards, which can actually induce SAM as well. And occurs, according to the literature, in up to 10% of these patients with subvalvular obstruction, which is caused by the secondary hypertrophy caused by that aortic stenosis. This can be predicted pre-op. You'll see flow acceleration, turbulence, high velocities going through the LV outflow tract. If you actually measure the diameter of the outflow tract as well on 2D, there appears to be a cutoff of around about 14 millimeters. Anything less than that, patients should be considered for a myomectomy at the time of their AVR. What about post-mitral repair? And there we have two images of SAM post-mitral repair. We all know it. We're expecting it in a patient who becomes unstable who's had their mitral repair. It occurs in up to about 14%, depending on what you read, which bit of literature. And the vast majority is that is going to be managed medically. It's very easily seen. It's seen on 2D echo. I suspect most of you are familiar with this. It's gone. But with the morphology of the ventricle and the direction of ejection from the apex through mid-chamber is obstructed by that basal septal hypertrophy. The flow picks up the anterior leaflet and drags into the LV outflow tract. So we have wide open MR at a time of dynamic outflow tract obstruction. Hemodynamically, it's a disaster. And without an echo, high PA pressures, low systemic pressures, you'd think we've got a failing heart here. Inotropy might be the thing to do, when in fact slowing them down, beta blockade, fluid bolus, vasoconstriction is what's going to widen out that LV outflow tract and reduce the SAM. There are various criteria which will predict SAM in patients having mitral repair. You can read those for yourself, and there's a very nice article from Maslow in the Red Journal just this year, just from January this year, which is definitely worth a read. And this is, let me see, Dr. Winslow showed you those fleeting images earlier, which is a patient with a congenital transposition, congenitally corrected transposition, who developed subpulmonary SAM, which we hadn't heard of before, but there it is, it's gone. He'd actually come in with systemic ventricular failure, his systemic right ventricle failing, and his systemic tricuspid valve leaking. He went for a tricuspid repair, systemic tricuspid repair, which failed, and had a prosthetic valve implanted. This was about 3 or 4 hours post-operatively, having been fairly comfortable, under sedation, quiet circulation. As he began to emerge, when he was being woken up, got his tachycardia, he ended up with subpulmonary SAM. This was attempted to be managed medically with big doses of beta blockers, lots of fluid, vasoconstriction, and we got fleeting moments where the SAM disappeared. But the mechanism of it was really the mechanical prosthesis in the systemic tricuspid position was really closing off, putting pressure on the subpulmonary outflow tract and bringing about SAM by that nature. As I say, we haven't heard about this before. And it ended up with this guy going back about 3 days later for his mitral valve replacement, his subpulmonary mitral valve replacement, and they ended up with a ventricle which looked like the image at the bottom, which you just about managed to see there. So, in summary, Pressure monitoring, often unhelpful. A patient who's not responding to initial measures, it's a prime indication for a rapid TOE, rapid diagnosis, rapid intervention to improve outcome in these patients. And I would take up Donna on her point, actually, that is there a position here to use continuous miniaturized TE monitoring in some patients selectively? I have no experience of it. There might be other people in the room who do have more experience of that. And my last slide, there are a few people, well, many of you who've come from different parts of the UK, London, Wythenshawe, Germany, Italy, here for a few days. Manchester's got a lot to offer. There's a lot of good food, culture, festivals, music. Hire a car and get out of Manchester. At the moment, the Lake District, which is where this is taken, is absolutely gorgeous, with all the flowers just beginning to appear. If you can get away from the M6, the further you get away from it, the more beautiful it is. It's definitely worth a trip. Thanks very much.